Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. So you've been doing echo sonography for how long?
So all in all modalities combined, about 18 years.
18 years. Awesome. And that's amazing. And you've just recently switched to this new position. How long ago?
So I started out doing vascular. I trained into echo, and then I took my first industry position at the end of 2020. And that's what made me relocate to Fort Worth, Texas. And just in the last year, I switched industry positions, and now I'm in a new space. I'm in the structural heart space. So
Awesome.
I'm no longer associated with ICE as far as directly, but ICE is still part of my daily life because we're using ICE in these procedures every day.
Okay. Awesome. And so for our audience, define what ICE is.
So ICE is the acronym for Intra Cardiac Echo. So we're all familiar with transthoracic echo or surface echo. We're familiar with transesophageal echo. But if you're not involved with cath lab or EP lab procedures, maybe you've never heard of ICE. And so ICE is a catheter-based type of echo modality where the transducer is at the tip of a catheter. And this catheter is inserted through the common femoral vein usually and advanced into the right atrium of the heart to start. And so you're imaging the heart from within the heart. And so instead of relying on a transesophageal doctor to run the echo machine and having an echocardiographer present as well, the physician is actually the one doing the manipulation to obtain the views. So they're clocking the catheter to go posterior into the heart. They're counterclocking to look more anteriorly in the heart. So they're the ones that are responsible for getting all the images.
Wow, but he kind of needs your experience to know which ways to turn and go to get
Absolutely.
some of
Yeah.
those. Yeah.
So
Because
one of
I
the
remember
interesting, go ahead.
in one of I remember doing TEEs and just sometimes having a difficult, I mean, you're limited to some degree, right? And how you can turn that camera to get, you can't look back onto yourself, kind of.
Absolutely. Yeah. And
So
so
there's,
one of the big advantages, so with the TE probe in the esophagus, there's some swing that you can manipulate. Like you can move the esophagus a little bit to kind of bend around and look around different structures.
right.
But it's limited. And the biggest, I think, benefit for intracardiac echo is that for a lot of the structural procedures, the transesophageal part is the worst part for the patient. So a lot of times you may walk into the procedure without having any sort of GI issue, but you may leave with one. And with ICE, sure, it's more invasive as far as you have to insert it into the common femoral vein. So you have an introducer sheath that's tied into this, but it's a small French size. And so once we're in the heart, you're able to flex this catheter quite a bit. And you're able to flex it in 4 different directions so you can see everything. And the real advantage of this is you're in the blood pool. So you don't have any interference, or there's less interference, compared to TEE. And so you're right next to the structures that you want to visualize. So the image quality is outstanding.
Yeah, I would imagine. So then you're still able to measure velocities of blood flows, right?
Absolutely. You can still do
Yeah.
it. So this is all duplex imaging. You're still able to do a full echo if you wanted to. For certain views, compared to traditional echo, you're not completely on access. So as far as doing certain like a symptoms biplane, you don't get like a full 4-chamber and a full 2-chamber per se. But you're able to look at ejection fraction. You can see if there's any sort of infarct, any kind of wall motion abnormalities. Definitely, when you're parallel to flow, in some of these views, we can get extremely accurate velocities and envelopes for the aortic valve and for the pulmonic valve. But definitely, yeah, we can see regurgitation with color Doppler. Some of the ultrasound machines are also capable of running M mode also, just like our traditional echo machines.
Oh, wow.
So yeah, you can basically do a full echo, which is quite
The
beneficial.
appendix isn't near as difficult to view.
The appendage?
Yeah.
No, in fact, so for the position where I was on ICE clinical, I spent the majority of my time in left atrial appendage closure procedures. And this is real advantageous because the ICE catheter was going across the transeptal puncture alongside the sheath for the LAO device. And so the tip of the ICE catheter was in the left atrium. And so you're right at the os of the appendage. And so you can replicate, the 3 main orthogonal views as you can in TEE. And the fact that you're right at the os, you get extremely accurate measurements. And you can, really accurately evaluate for endoleak, post implantation, using color Doppler.
Awesome. Yeah, so amazing. With such little, you almost wonder why we do TEEs anymore, right?
Yeah, that's still one of the, if you're in the ICE clinical position, that's one thing that you're trying to educate physicians, like, hey, this is a very good way of imaging. And there's some different scenarios where TE is contraindicated, so they kind of lean towards using ICE. But for the biggest reason is that depending on what hospital we're in, maybe obtaining a TE or having the whole TE service line, getting that scheduled can be an issue, and that can delay procedural cases or even cancel them sometimes because you don't have that TE coverage. So with ICE, you completely get rid of that whole factor.
Nice.
And so, yeah, and that's the biggest benefit that the physicians like. And when you have an implanting physician and a TE physician, sometimes there's a loss in translation when the implanting physician says, hey, can you look this way, that way? And then there's always, oh, no, the other way.
Yeah.
And so, so sometimes just getting rid of that whole part of it out of the way is beneficial, just to use ICE and have them get their own images.
Right. So tell me, how long is the ultrasound on the end of the catheter? How big
So
is
it ranges, depending on the manufacturer, it's right around a centimeter, the stack, the crystal stack. It can range from 90 to 100 centimeters, depending on what catheter we're talking about. And so the transducer stack is just at the very tip of that. And so it's side fire technology. And so meaning it's side facing. So once we go into the heart, in order to see all parts of the heart, we have to clock the catheter. So when we talk about clockwise rotation or counterclocking, we're talking about moving that fan, looking posteriorly and then looking anteriorly. And so those are the types of movements we're talking about when we're looking at certain structures. So if we're looking at the CS os or the mitral valve or the left atrial appendage, those are anterior structures. If we're looking at the right pulmonary veins, those are more posterior structures. And so when we're in the heart, when we're trying to obtain a certain view, we can kind of see where we're at, and we'll say, hey, doc, maybe you want to counterclock a little bit to look more anteriorly, or more anterior, or clock to look more posterior. And then that's only one set of movements. The other set of movements is, are we too high in the heart, or are we too low in the heart? And so ideally, when we start off, we're in this home view where we're in the mid right atrium. And so in this home view, we have the right atrium, the tricuspid valve, and the right ventricle, and that's kind of our home starting point. And sometimes if you are too high, we're like up in the SVC. So we're not able to see certain structures. So we have to say, hey, doc, can you withdraw just a little bit? And vice versa, we may be too low. We might still be kind of looking in the liver in the IVC, and we're not past the eustachian valve. So we say, hey, doc, can you kind of advance a little bit so we can get inside the right atrium?
Wow. Fun. How does it feel to be that much of a partner with a physician?
I think that part is pretty amazing.
Yeah.
And, and it's the thing that was mind blowing to me is I had worked in different capacities at different hospitals, outpatient clinics, but I was never part of any cath lab procedures or EP lab procedures. And if you're not exposed to it, or if you're not working in a facility that offers those procedures, maybe you don't even know that they're available. And so once I found out that this was a thing, I mean, I found out right away that this is done all day, every day, all across the world. And so it was pretty mind blowing to find out, once you're in these procedures, the type of technologies that are out there. And I was kind of missing out. And so this opened up a
Yeah.
whole new world of technology and all these different procedures. And the thing that I'm excited about is that for all these new structural heart devices that are coming out, these transcatheter-based devices, it seems like a lot of the vendors, a lot of the reps for these products have backgrounds in ultrasound and specifically echo. And so just across the board, I'm seeing more and more and more echocardiographers getting these medical device positions because a lot of these devices are very hemodynamically dependent on echo to evaluate whether they're successful or not. So you
Right.
need someone with echo experience to really kind of quantify everything.
Yeah. Yeah.
So that's what's exciting to me.
Yeah. Yeah, that's super exciting for our occupation as ultrasound techs, that
It's
there's a
huge.
new avenue for us to go, right?
It's huge. It's huge. And even just recently, like let's say in the last 2 years, I've been seeing higher level echo positions. So in the past, maybe you can become a technical director of an echocardiography lab. But that's pretty much it. Like that's where you kind of your ceiling was at. But what I'm seeing now is I'm seeing specialty structural heart echocardiographers. So these are sonographers specifically in these medical device procedures because they're so specialized and you need certain information. There's certain people that are designated to run these echoes. So it's pretty neat when I'm in these rooms and there's, let's say, 5 or 10 people, all with their own specialty. Everyone defers to the echocardiographer to see if this is a successful implant or not. And so to see that high level of responsibility and trust given to the sonographer, to me, that's pretty gratifying.
Yeah. Yeah. Yeah, because this device is used to help replace valves, right? As you mentioned, right?
Yeah,
Replace
it's used
valves
for they
and
use it for transcatheter aortic valve replacements, pulmonic valve replacements. So now mitral valve repair, tricuspid valve repair.
right.
Um, they use it for atrial septal defect and PFO repairs for septal occlusions. And then, I mean, there's another branch of the use for this device. They also use it in EP procedures. And so when they have ice in the heart, they're able to see in a live manner the catheter for the ablation, right? The ablation catheter is actually making contact with the tissue. So it's real important to observe that during the case. And then also you can monitor for effusion, the entire time. And so, yeah, this device has kind of taken over. And now that we're in this advent of 3D ice catheters, that's kind of the talk of the town now is
Yeah,
what.
so I was gonna come back to that, but yeah, now that we're there, tell us the advantages to the 3D as opposed to
So
just the 2D.
yeah, so with the 3D ice catheter, instead of the physician making all sorts of movements to get their work in view and to look at pre and post measurements, um, they're able to just have the catheter in a certain position. And on the ultrasound machine, you can actually steer the beam. So you can, X-plane it or
Okay.
triplane it, and you can look at multiple orthogonal views just from one placement, the initial placement of the ice catheter. There's still some fine movement, but for the most part, the echocardiographer or the clinical that's with the device, they're able to enhance the ultrasound machine, obtain a 3D volume, and the same way you would obtain a 3D volume in TEE, they're just doing it on an ice catheter now. And so to be able to look at everything in an X, Y, and Z axis and rotate it how you want is pretty amazing.
Yeah. Wow. It kind of blows my mind a little bit, right? Because I just got back from the STMS conference, and so meeting new people and talking about new and different things, and trying to find ways to kind of push our profession forward. And this is definitely one of them, right? Like, and stressing the importance of good imaging and understanding your physics and your placements and your positions and anatomy. There's several different new things out to help understand anatomy. But especially like you were saying, the valves are anterior and these valves are posterior, and different things. Just understanding that enough um is exciting, because
No,
I
absolutely.
think
In fact,
that's where we go to the more advanced practice sonography kind
no, I
of.
think so. And so you had mentioned, so there's some limitations with transthoracic echo, as we know. If you don't have the right angle, like let's say we're looking at the aortic valve, and for a transcatheter aortic valve replacement for a TAVR procedure, the patient is supine, right? And so to try to get a great 5-chamber from a transthoracic probe, you're not always going to get that nice view
Right.
where you're parallel to flow to get an accurate measurement to look at your mean gradient. But with ICE, you're able to get a completely parallel to flow, so your mean gradient is completely accurate, and you're parallel to flow. So it's very advantageous for certain procedures to utilize ICE instead of the other modalities. Absolutely.
Wow, it's amazing. I'm excited. I'm excited to be a part of the profession with your knowledge and your expertise and different things such as that. Because we are important to the medical staff, right? And with the way in which medicine is progressing, right? We were talking in one conversation with several people about how the sonographer isn't even talking to the physician anymore, that we're just doing the work and then send it to the doctor, and how we miss a lot of learning and a lot of um, growth in those times. So having to create a position where we're back to working side by side alongside the physician to um, better their skills as well as ours, and to share that information back and forth.
No, I absolutely agree. And I think one of the biggest differences between ultrasound and the other the imaging and radiology is that, we're not just technicians. We're not just putting the patient inside of a big apparatus, and, the apparatus gets all the images, and then we prepare it and submit it to the physician. And everyone has, the preference, everyone has their skill set. But for sonographers, we're actually the ones where we go and find the problem. And that's why it takes extremely, due diligence to find the issue and to document it properly. Because you can make an ultrasound, you can make something look positive, you can make it, look negative, depending on how thorough you are. And so I think that's the biggest difference between sonographers and all the other type of imaging modalities, is that we're tasked to actually find the problem. And with vascular, I mean, you're looking at the whole body, you're running from the pelvic area down to the foot. And so you're going inch by inch all the way down, looking at all these different vessels. And if you miss a section, well, maybe you missed a part of the disease that we didn't document. But for me, I had started out doing vascular, and I really enjoyed it, really loved it. But once I started doing echo, you were able to put kind of the whole puzzle together. And so you see how hemodynamically everything is tied into each other. And you can see the effect of what heart failure does, on the periphery, and vice versa. And so that's what I really enjoyed, is how everything is tied together.
Yeah, I will say this, that when I thought I was burnt out on high risk OB and I went in to learn vascular and then eventually adult echo, I will tell you that those patients have kept me on the treadmill.
It's funny the way that works, right?
Right? Like it's definitely been a life of extra motivation, right? To like be active and how that affects your body, and even hydration, how that affects the appearance of your heart on echo studies and different things. So
Yeah, that and it's funny that you mentioned that. This is a kind of a daily topic in my current role, because even for every patient when they go in and get access, and if you're dehydrated, they have a very hard time getting access to the common femoral vein. It's too deflated. And so, I mean, hydration just plays a huge role on how well your heart's pumping and if you're volume overloaded or volume depleted. So yeah, you're right. Being hydrated is so important. And maybe we didn't really think about it too much, but now that we see it firsthand every day, just
right.
as you mentioned with the treadmill, it's funny how a lot of people don't have any issues at rest, but once you get on the treadmill, you know, you start to see problems almost immediately.
Yeah,
Uh,
right. Right. Oh, yeah. So, yeah, I'm of the age that I remember, the long recovery of them cracking the chest open, right?
mhm.
That's used to be how we fixed it. I've been doing ultrasound 28 years, and so
Yeah.
back in the day, that was what we did. And so the fact that you're just putting a little hole in their growing area, and your recovery is a fraction of the time of cracking somebody's chest open to replace a valve, or even to stent an artery, or whatever.
No,
um
it's kind of just in the last 10 years or so. It's just the growth has been exponential on the types of things we're doing now. And with the recovery time, a lot of these procedures are done under moderate sedation. You don't even have to be under general anesthesia for these procedures. So just that fact alone is mind blowing. And the fact that they're relying so much on ultrasound, specifically ICE, for a lot of these procedures, that limits the amount of radiation that the
right.
patient and the physician and the lab staff is exposed to. And so that's a huge benefit as well.
Yeah. So are there any counter indications for um the ice?
Or contraindications, I mean, there's always a risk. It's a catheter that you're moving around in the heart. But these catheters are approved for the great vessels and for the four chambers of the heart. And as long as you're, very careful, not to say that accidents can't happen or there's complications that don't happen, but all in all, it's very safe.
Yeah. So not too many, not if at all, any contraindication?
No, I mean, so if there's any sort of issue with gaining access to the common femoral vein, that can present an issue,
Right.
of being able to advance the catheter. But once you have access, no, not so much.
Awesome. Which is amazing, right? That means anybody could have it done. So
Absolutely.
that's awesome. So I know when we talked previously, you talked about helping others get into this field because you're so passionate about it, and how you'd like to kind of share how and help others kind of cross that barrier sometimes.
No, absolutely. In fact, I think that one of the things like most kind of at this stage where I'm at in my life is that almost daily I'll have messages, in my inbox and say, "Hey, I saw your profile. How did you get into medical devices? I've been trying to do this for a long time." And just to kind of share my experience and offer, kind of tips on how to break in, and then finding out that some of these people, actually end up getting in, and that they're successful in what they're doing. I mean, that's very gratifying. And so being that, I know you've been at it, you said 28 years, and I was doing it almost, 18 years. Maybe a lot of times when you first started, people weren't willing to share information. And I think, moving forward, in order to grow the field, I think that what we have to do, kind of like what you're doing now, and the passion that you have by putting on these lessons and these podcasts to put ultrasound in the spotlight, is that we need to share information. And I mean, information is gold. And I think that once you get a little bit of the information that you need, then you're able to kind of, investigate it and research it and, break in. But yeah, I totally love talking to people and sharing my experience and what I did in order to get into the field. And yeah, that's very, very gratifying.
Yeah, and I think so much of the time, and this was part of the conversation, like I spoke of earlier, it's about relationships, right? And mentorships. And I think, and mentoring people, and you had mentioned about mentoring and helping others. And yeah, how because we're not signing off to a physician all the time or having that relationship um with the physician, I think it really hinders us, right, to grow our profession or to even grow us as a person. And I think, hurting people hurt people, but healed people heal people, right? And
Right.
so, um, or accomplished people, I worked with some really very skilled people when I was in Minnesota, and some were just not so willing to share. You
Right.
know, they're willing to go in and do it, you know, but not really willing to share the step by step to get there, how they got there. So I think sharing and mentoring is another big step for our profession. And
No, it
so,
is. It is. And it's not a like, don't just show me how to do it, but what's the why and the how, right?
right,
And what are the
understanding.
what are the tertiary type of levels to understanding what we're looking for? I had a
Right.
physician one time tell me, this is an emergency room ICU doc, and he said, man, I see how passionate you are about echo. He says, I've been trying to get into echo. And so over the course of a couple of years, I taught him pretty much everything I knew about echo. And we go over all the different exams that he would order. And we talk about, why this is this way and why it's that way. And over the course of those 2 years, he was like, now I get it. He's like, the echocardiogram is the single most important test that I order every single day on my patients. And having that rapport with the physicians where they understand the information that you're trying to gather for them, like, it's so important. And it's not just, picture taking where, you
Right.
have that kind of that negative connotation sometimes,
Hmm.
that relates to sonographers, but it's the opposite of that. I mean, sonographers are tasked to find the most detailed information to help make a diagnosis for a patient that can change their quality of life, so
Right.
and so
Right.
that's why you have to, approach each exam with extreme pride, that you have the knowledge and the experience to obtain this information. So I always felt, um, you know, very appreciative that I got into this field to be able to do an exam that would help better someone's life, and change the treatment and provide for a better quality of life. Absolutely.
Yeah, and I think it's the relationship sometimes of just, as a traveler now, it's the challenge sometimes is like learning how the doctor thinks, right? So if I can learn how he thinks, I can head off trouble before he asks about it,
Right.
right? And so I think um in order to curtail our exams around their preferences and what they're looking for and how they view things is vital to a successful um exam, right? um Not only are approved, our AIUM standards, of certain imaging that we need to get, but every doctor looks at things differently, and I've learned that so much in travel. But if you can learn how they think, right, then you're much more successful for them in order to help treat the patient.
Absolutely. And once you figure them out, then it's time on to the next assignment, right?
Right, right.
Once
Exactly,
you once
right?
once you figured that one out.
Right, right. But man, do people think differently, it's just amazing. And it's you have to be careful not to make assumptions, right? So, and I'm sure
Absolutely.
that in your field as well. So,
Yeah, every hospital is different. Every lab is different. They all have their own different protocols. But yeah, you're completely right. You can have 10 different doctors look at an echo and interpret it 10 different ways.
yeah, yeah,
Absolutely. And unfortunately, sometimes the way it's read out, that's in that patient's file for the rest of their lives. So they're treated that way as if they have an issue or don't have an issue based off of
right.
how it was read. Um, yeah, I completely understand though what you're saying.
Yeah. So I think our field of ultrasound is growing to need those advanced practice to be able to do things like ice and different things and show up in the OR, right? There's so many
It's
more.
huge. It's huge. I mean, every single day, these procedures, like I said, there's usually either a specialized echo person, helping out with TEE, or there's someone that's in the clinical medical device position, to help out with echo as well in the ICE space. But yeah, it's exploding. Even let's say 15 years ago, I was working at a neurology office, and this is where I learned transcranial Doppler. So flash forward to now, transcranial Doppler is something that's kind of in the background, but it's so needed. They're doing bubble studies with transcranial Doppler because of the specificity, and it's kind of more sensitive than looking at bubble studies for transthoracic or transesophageal. So just the same technology, but looking at different things, I think is still there's still so many things out there that can be investigated, with ultrasound.
Yeah. Yeah. And I think it's just going to bloom from there, right? In the
Absolutely.
OB world, surgery and the fetus on the fetus is just starting to like implode, So, definitely needing high, um, skilled ultrasound people in those fields for sure.
Yeah, for sure. And I know you had mentioned that there's certain procedures in our previous conversation. Can you repeat that? Like the common procedure that you're seeing now, transcatheter based?
For OB
Yeah,
or high risk OB,
yeah.
mostly twin to twin transfusion um kind of procedures where we do an ablation across the placenta to keep them from sharing blood flow.
That's amazing.
So that's a huge one. They're also repairing some spina bifidus and seeing huge increase in of mobility of the lower extremities for those children that they um cover that myelomeningeal seal. So yeah, ultrasound in the surgery field is definitely growing in probably all areas, a lot of different areas.
Yeah, and with the advent of these new catheters and the processing power of some of these ultrasound machines, it's just mind blowing now compared to how it used to be. And I know you probably started out on maybe some of the machines that I used as well back in
Yeah.
the day. But even just in the last few years, the advancements in the technology of some of these ultrasound machines is spectacular. Even looking at some vascular images of the carotid artery or something like that, the amount of detail that you can see within the three different layers of the vessel wall is just mind blowing.
Isn't
Compared
that
to what we
amazing?
used to see. Yeah,
Yeah.
it's just, I mean, it's exciting to be part of it and to be able to see this and just the improvement in healthcare overall based off of what we're able to see non-invasively with ultrasound is just, I mean, I'm like I said, I'm very excited to see where this is going and very fortunate to have been, a part of it for a good part of my life.
Yeah.
But yeah, compared to when I first started doing vascular, I remember doing physiologic studies with 811 Parks, Doppler, pencil probe, doing segmental pressures, just with a little Doppler pencil probe, starting from the common femoral going all the way down to the foot. And that's what I spent most of my day doing. And so
Yeah.
we weren't even doing imaging. This is all just
Right.
just just based off of sound. And
Exactly.
to see what we're doing now is very amazing.
Yeah. So tell me, Patrick, at the end of the day, what do you do to uh increase your frequency? What kind of things do you do to kind of fill your fuel tank
Yeah,
that's not
that's a
related to
yeah.
ultrasound?
No, I know. In fact, it's very hard, and once you're in this medical device space, it's hard to be consistent and to carve out time for yourself to do those sort of things because it's very important, or else you'll get burnt out. But
Right.
anything outdoors, anything that involves being active. I mean, I moved from New Mexico to Texas a few years ago, so I don't have the same sort of um, outdoor landscaping as I did in New Mexico. I mean, within 30 minutes or 60 minutes, you can be in the mesas or in the mountains or the valleys or in the rivers or the lakes. Out here in Texas, it's a little bit different. It has
Yeah.
its own beauty, but anytime that I have a chance, I'm always outside. I love exercising. Um, Anything involved with hiking, running, kayaking, I'm doing it. But I enjoy working on home projects, doing landscaping outside. We have very nice weather out here. In fact, it's probably still like 95 degrees out here, where most of the country is kind of cooling down. We're still kind of in a little heat wave right now.
Yeah.
But yeah, so I mean, just to recharge, anything outdoors is that's kind of where my happy place is at.
Artwork.
Love artwork. I've always been into photography. I've always been into making things with my hands, trying to repair things. I did silversmithing before I got into ultrasound school. I was making jewelry for a number of years, selling in Albuquerque and in the Santa Fe Plaza. I got into glass making, and so that was really fun. But yeah, anything where I can kind of make something from nothing is very enjoyable.
Awesome. Awesome. Creative you are, that's for sure.
Yeah.
That's awesome. Well, thank you for your time. And if anyone wants to reach out to you on LinkedIn, as you had
Absolutely.
said,
Yeah, yeah. No, I thank you for
before,
having
you'd
me
be
on.
willing
No, absolutely.
to
They can
share
just
some
they can just
insights.
message me and I'd be happy to help out and offer any sort of assistance if they have questions. Thank you for having me on, and thank you for taking time out of your busy day.
Oh,
But
thank
it's
you.
people like you that are putting ultrasound in the spotlight, and there's people in my family, family friends, or friends of friends that are like, hey, how do you get into ultrasound? And so even now, this day, ultrasound is still a great field to get into, even from out of high school.
Absolutely.
There's just so many opportunities right now, and I think that right now, even though in some areas it may be saturated, there's so many new technologies coming out where we still need more sonographers that specialize in these subspecialties.
Yeah.
So yeah, very, very exciting, and anything ultrasound I love.
Yeah. Always room to grow, um, always a shortage. And as I shared with someone else, it's a great field. You know, during good times, economic good times or bad times, we've always had jobs.
No, it's funny. So on LinkedIn, there's a couple of recruiters that they'll send me, hey, if you know a person that lives in this area for an echo position, let me know. And I'll see some of the positions and what they're offering, the benefits and the pay. And I'm like, man, where was this when I was doing echo?
Yeah,
Uh,
right.
so I can see, especially like in West Texas, West Texas, it's basically its own country, just geographic wise, just the scale of it. And
Right.
there's all these small towns everywhere, and it's hard to fill positions there. And so some of the pay rates that I'm seeing for Echo is mind blowing. I'm happy for them.
Yeah.
But yeah, there's always going to be a need. Even in cities where there's multiple schools, it seems like there is always a shortage, always,
Yeah.
especially for Echo and Vascular. Um, those are the two positions that you know I mean, just the structural heart and the vascular space is kind of exploding, and I think what goes along with that is having specialized people, vascular and echocardiographers that also need to kind of follow along, in that same sequence. But yeah, we're always going to need more. Absolutely.
Yeah. Well, thank you. Thank you so much for your time, for your expertise, for sharing your knowledge. Thanks for, I know you're super busy and you've probably traveled thousands of miles this week, and to come back and share that time with me to share with others is greatly appreciated. So thanks for your contribution to ultrasound. Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.